Welcome to this step-by-step guide on performing laparoscopic cholecystectomy by Dr. Manzar Ali. Prepare the OR, surgeon stands on the patient left side, assistant stand on the right side. Patient is placed in supine position to improve access to gallbladder. Table is tilted in reverse Dunlunberge position, lifting the head and lowering the feet. After proper preparation and draped in a sterile fashion, 4 laparoscopic ports are inserted and pneumoperitoneum is created by CO2 insufflation. One for camera port of about 10 mm in umbilicus, second is epigastric port of 10 mm and third is subcostal, fourth is anterior axillary port, both of which are of 5 mm. After visualization of all the structures, an atraumatic forceps is being inserted by assistant through the fourth port and the gallbladder is gently pulled upwards and laterally towards the diaphragm. Once adhesions are identified, the surgeon is applying traction and counter traction to safely separate the gallbladder from surrounding structures. Surgeon is using a grasper in the left hand to provide traction and using cautery from the right hand to break these adhesions. This is done very carefully. After removing all these adhesions, now you can see the rovius sulcus. Here an imaginary R4U line is drawn, extending from the rovius sulcus roof to the segment 4 base till the umbilical fissure. And this is the landmark for safe dissection. Again, by traction and counter traction, posterior dissection and anterior dissection is being done. Surgeon is carefully separating the gallbladder from its attachment to the liver using sharp and blunt dissection. Window is being created by dissecting the peritoneal layer that attaches the gallbladder to the liver bed around the cystic duct and cystic artery. Here, the surgeon demonstrates the critical view of safety, which is crucial for safe dissection during laparoscopic cholecystectomy. To achieve CVS, surgeon must meet 3 criteria. First is, only 2 structures should be clearly connected to gallbladder. Second is, lower third of gallbladder should be separated from the liver to expose the cystic plate. Third is, the hepatocystic triangle should be completely clear of tissue. Critical view of safety was introduced to reduce the number of biliary injuries that occur during laparoscopic cholecystectomy. It is considered gold standard for performing safe laparoscopic cholecystectomies. As the camera zoom in, now we can see the boundaries of Galler's triangle. It is bounded laterally by the cystic duct, superiorly by the cystic artery, and medially by the common hepatic duct. Here, the surgeon demonstrates the careful identification of critical structures like CBD and duodenum. And here again you will see a belly-wide structure, CBD, and rovius sulcus, above which you are doing safe dissection, and if you go below, that is an unsafe area. After achieving CVS, surgeon is applying clip on the cystic artery and it is ligated proximally, and further dissection for clearance is being done. Now the cystic duct is carefully isolated and the surgeon is applying a clip at the base of the cystic duct and a second clip slightly above it and a third clip at the base of the gallbladder. And now the surgeon is cutting the cystic duct carefully. With the cystic duct and cystic artery being clipped, now the surgeon is removing the gallbladder from the liver bed with gentle dissection and retraction. And now the gallbladder is being carefully removed through the epigastric port. Thanks for watching.